Good evening, and welcome to Weill Cornell Medicine's educational webinar series. Please feel free to drop where you're joining from tonight in the chat. I'm Rebecca, and tonight we are joined by Dr. Srikanth Reddy Boddu. Before we begin, hi. Enabling captions, thanks so much. Before we begin, a few quick housekeeping items. This session is being recorded and will be available within 24 hours. We'll send it to the email that you registered with. Please keep your microphones muted throughout the presentation. You can submit questions anytime using the Q&A feature, and we will address as many as possible in the final segment. It looks like we have a good group on the line. Oh, I've got some people in the chat saying where they're from. I'm seeing some New Yorkers. That's great. I'm in Brooklyn. It looks like we've got a good group on the line. So I'm going to dive right in. So Dr. Boddu is an experienced interventional neuroradiologist at Weill Cornell Medicine. His areas of clinical expertise include acute stroke and treatment of cerebrovascular disorders, including, So Dr. Boddu also specializes in venous sinus stenting for pseudotumor cerebri and venous pulsatile tinnitus. And we'll get into whether or not I'm saying that correctly later. Dr. Boddu sees patients and performs surgery at New York Presbyterian Queens and New York Presbyterian Weill Cornell Medicine, Weill Cornell Medical Center. Dr. Boddu, anything you'd like to add? Any additional context?
No, we are been treating the conditions for almost a decade now. And we are one of the most experienced centers in the country. Yes, we have a wide experience across the venous pathology, like pulsatile tinnitus, pseudotumor, and also CSF venous fistulas. And the standard regular procedures like brain and spine, AVM, aneurysms, and fistulas, as well as compression fractures for the osteoporosis and metastasis.
Fantastic. Thanks so much. So we're going to get started by getting to know you all a little bit, our audience. So I'm going to launch our first poll. What brings you to tonight's webinar? And I am seeing a question in the chat. This presentation will be available later. It will be sent to the email that you registered with. And it will be on our YouTube as well. So yeah, I think a lot of people are coming because either they or a loved one are diagnosed or experiencing pulsatile tinnitus symptoms. And here, I'm gonna give it a couple more seconds and then I'll end the poll. All right. So mostly our participants are experiencing unexplained pulsatile tinnitus symptoms or they've been diagnosed. So that's really great to know. Wonderful for us to understand. And great. So I am going to turn it over to Dr. Boddu for his presentation.
Thank you, Rebecca. So good evening, everyone. Thanks for taking time in your busy evenings to attend the webinar. I'm more intrigued seeing it is almost 60% either diagnosed or suffering from the noise, but how many were told that you have to live with it, or there is no treatment and it is just in your head, this type of sentences, because that is one of the common things I hear when the patients come to see me, because they already saw a few and that's what they were told. So diving into the presentation today. It is either you call it as a tinnitus or tinnitus. It means the ringing noise in your ears in the absence of any external stimulus or external source. And each person describes it differently. And they say, bottom line, they are trying to say is we are hearing our heartbeat in our ears. And some say either it is a ringing, whooshing, hissing, and even people say, depending on their backgrounds, they say, I hear the washer dryer going on in my house all the time, even though I did not turn it on. Some people say it is a ceiling fan is continuously going on, or water is running in the tap. It's a different ways how they explain it. But when it comes to the clinical aspect, either it can be subjective, which means only the patient is hearing it, and rarely objective when the examining physician can also hear along with the patient by using a stethoscope as a buoy or these things. So that is an objective. Next slide. So whenever we see the patient, there are two main things from my side. I am not going to take care of every aspect of the tinnitus, but my area of expertise is the vascular nature of the tinnitus. So we ask the patients, does this noise go along with your heartbeat, or it changes with your position, like trying to tell us whether it is in vascular in origin, means it is related to the blood vessels. When it is blood vessels, it can be either arterial or venous system. Then goes into the next one to understand the risk or the severity. Is this the noise goes away with compressing your neck or turning your neck to one side or the other? That will help us to tell if it is a venous. If it is noise is going away with the neck compression or turning your neck, it mostly favors the venous, but if it does not mean it is not venous. So that is one thing we need to understand. Next one. So to understand the burden of the tinnitus, 75% of the population experience at least one episode of ringing of ears in their lifetime. And unfortunately, for some people, it is going to be multiple episodes. When you look at the global burden, around 740 million people are affected by the tinnitus, and almost 1/6 of them, that is around 120 million, have severe tinnitus, impairing their quality of life. And unfortunately, 1/3 of the patients, it does not matter, it is not vascular, it is not bony, they don't have an underlying cause for their tinnitus. And I am pretty certain it is another at least 1/3 of the patients were underdiagnosed or undiagnosed for their causes for the tinnitus. And when you look at the other issues, the most common issues, it is much easier for me to talk about the vascular reasons, but there are other reasons as well that some we can control, some we cannot. It is the controlling things or the lifestyle, smoking and excessive alcohol, these things, can lead to the tinnitus. And any patients with a prior history of a head trauma, concussions, and these things can have a temporary tinnitus. Also, when it comes to the age, patients, the presbyacusis, which is age-related hearing loss, is mostly associated with some component of the tinnitus. Next one. But this is a slide, I'm more seeing it. And, it is when the American Tinnitus Association, they formed a single question to the public. It is how much the tinnitus affects your quality of life. And this is the outline of the responses from the population. And these are not the patients, this is the population. That is the interesting thing that caught to me. And if you see 2/3 of this thing, have some sort of significant impact in their quality of life. It is And only 1/3 of the patients or population participated in that study showed, yes, it is annoying, but it is not affecting our quality. But 2/3 have either trouble concentrating, sleep problems, anxiety, depression, or the social isolation, and everything it is that is impacting their quality of life. And probably in terms of the picture, the iceberg phenomenon on the right side, it shows, yes, the what we see in the clinical areas is only the auditory component of these patients saying, I'm having difficulty in hearing or their noise in the ears. But most of these, there is underneath, the majority, 2/3 are underdiagnosed or even not even reporting to the that they have the tinnitus, and they start to just keep thinking about it, and then it is they are trying to use the uh, ways to minimize the symptoms like hearing aids or the background music or the auditory treatments and these things, and eventually they go down in the setting of chronic mental health conditions. It is, I will show you in the subsequent slides how much it is impacting. And they go through the process of a chronic stress, anxiety, depression, insomnia, and PTSD, post-traumatic stress disorder. And that is like a sinking down slowly. That is the impact of this noise. Next one. So it is when it comes to the prevalence, like if I had to put it into the words of the two pictures we just saw, it is that tinnitus is a widespread condition. It affects millions of people, and it is present across all ages. Yes, the reasons can be different, and it is very commonly underdiagnosed and undertreated. And we know that now it is many patients suffer in silence, and in spite of it is impacting their quality of life significantly. And in a way, it is causing not only a huge burden to the health system, but also financial burden to the country, nation's financial burden. Okay, next one. So the recent study that is from 2024, it is last year, and it shows it is the more than half of the patients are suffering. Either they are struggling with the sleep deprivation, emotional upset, or the impairing the daily tasks like ability to concentrate and these things. You can look at the numbers, the first two, that almost half or more than half of the patients are difficulty concentration and sleep deprivation. And the emotional component and the psychological toll on these patients is pretty significant. It is more than half of the patients are going through that one. Next slide, please. So when it comes to how we validate, how we measure the severity of the patients when we see them in the clinic, this is a questionnaire, what you are seeing on the right-hand side. So if I had to break it down, it is a validated and a self-reporting questionnaire by the patients. Remember, we are measuring the quality of life or impact on the quality of life for these patients. So only a patient can tell, depending on what is their quality, because the inability to sleep or inability to concentrate or focus is different for a 30-year-old versus a 80 or a 85-year-old patient. So those things, so each only patient can tell you how much it is impacting their quality of life. So it contains 25 questions. Each question carries either 0, 2, or 4 points. Based on those grading on those points, sum it up, and then we come to the grade 1 or 2. You call them as a mild. It is minimal impact, and we put them to the medical management. And grade 3 is a moderate. That is where it varies depending on the patient's quality of life, whether you go for the medical management or the treatment. And grade 4, 5, these are the patients with the severe and they require a definitive interventional treatment. These are the patients affecting the sleep, concentration, and work relations, or these are going off. And it is mainly we are trying to focus on the patients on a grade 4 and grade 5, and moderate, that is a grade 3 patients, and who it is affecting their quality of life for them. Next one. So when it comes to the clinical approach. It is everything starts with a clinical exam, a good history from the patient. Just we need to hear. Patient have been hearing this noise for years, so it won't, it won't cost us hearing the patient's story for 10-15 minutes. So hear to the patient and main focus on how it is affecting their quality of life. And the common tests like a compression, neck turning test, and see for any obvious neurologic exam. And also it is we classify, it is based on that to see if it is a venous arterial pathology. The baseline investigations we need in all these patients is MRI of the brain with and without contrast, MRA, that is MR arteriography of the brain without contrast, and MR venography of the brain with and without contrast. So these are the three baseline investigations for these patients. Next one. So going back to the the vascular causes for this tinnitus, you can broadly say them as an arterial causes. These are on the left-hand corner, or in the center, you can group them as an arteriovenous junction. And more on the right side here, it is the venous causes. So one end it is arterial causes, one end it is a venous causes, and in the middle where the junction, arteries and veins where they meet. These are the three categories we commonly see them. Next. So the arterial causes, usual, it is either you have a dissection because depending on where the dissection is, the vessels, the smaller vessels, ICA, can give rise to the labyrinthine artery that supplies to your inner ears, and the internal carotid artery can give the stapedial artery. So any dissections here usually seen in the trauma settings, or even you can see in the spontaneous scenario dissection. The tinnitus is noted in these situations, and usually it is a self-limiting in majority of the patients. All that we need is identifying in the right time and just treat them with either antiplatelets or anticoagulant, depending on the scenario. And it is if we find an obvious aneurysms, yes, that can cause the tinnitus in these patients, and the treatment of the aneurysm based on the appropriate setting, either with an embolization or a stentosis, different modalities of embolization. Nowadays, most of these aneurysms are treated with endovascular approach without need for an open surgery in these patients. And also comes another context of the vascular loops, where there is a branches of the especially ICA branch that loops across your 7th and 8th cranial nerve that supplies to your ear. And whenever the artery continuously pulsates and it touches the nerve, it is transmitting that sensation to the nerves. And then you are hearing that noise all the time. And this one, the more definitive treatment is a microvascular decompression. It is an open surgical procedure, but it is mainly the diagnosis of exclusion, but we need to exclude all other major related causes. Okay. When it comes to the arteriovenous junction, that means it is where the arteries, which is a high pressure system, and the venous, that is the low pressure system in your head, where they meet. That junction, it is the causes, that is usually dural arteriovenous fistula or the AVM, arteriovenous malformations. So most of the time, the dural AV fistula are acquired. That means not present at the birth, they are acquired after. Whereas AVM, arteriovenous malformation, is present at birth. And this has a central nidus, whereas dural AVF don't have a nidus. But all things aside, so the main thing is arterial is the high pressure system carries around 120 millimeters of mercury at least, that pressure. The venous is a low pressure system carrying 5 to 10 mmHg. So the veins are not designed to handle the high pressure coming from the arteries into them. So at anywhere in the body, these two networks are separated by something called a capillary network. So what is a capillary network? Means it's a tortuous bed of blood vessels So by the time the high flow, high pressure blood crosses the capillary bed and reaches the venous system, the high pressure is dampened and becomes the low pressure. But the problem here is there is no capillary network. There is no dampening network between these arteries and veins. That is when you call these fistula or AVM. So that means the high pressure arterial blood is being directly dumped into the low pressure venous system. That increases your risk of not only the tinnitus, headaches, and all these symptoms, but it increases the risk of bleeding, because when the high pressure is being dumped into the low pressure and the low pressure system cannot hold that pressure, it can explode. So depending on what is the grade or classification of that dural fistula, you carry a risk of 2 to 30% risk of bleeding per year, depending on what grade you are seeing it. And when it comes to them, the most definitive test is diagnostic cerebral angiogram, or called as a catheter angiogram, which is the gold standard, which helps us to classify. And by classifying, you will know what is the risk of a bleeding you are dealing with. And also it helps us to strategize our treatment. Next one. And when it comes to the venous causes, the most common thing is the IIH, that is idiopathic intracranial hypertension, and also called as a pseudotumor cerebri. And if you notice it, more than half of these patients have pulsatile tinnitus in their as their presenting symptom. And yes, headaches and the visual symptoms, the three common things, it is when it affects the patients, either if patients can present with the superficial symptoms, which is headaches, noise in the ears, that is tinnitus, or visual symptoms. And the more it starts to affect the deeper component or a deeper system of the deep venous system in the brain, patient starts to have a dizziness, memory, balance, cognition issues. So this is all one spectrum. I mean, we see the patients like trying to see multiple physicians. Yes, you are getting addressed the different symptoms, but the underlying problem or underlying pathology is a single one. So we need to address the underlying problem rather than addressing the different symptoms. So this is where means this is the patients who are having the narrowing of the veins. Because if you think whatever blood goes into the brain has to come out of the brain. Unlike the kids who has a soft patches on the heads, adults, the skull is a closed box. Whatever goes in has to come out. The arteries takes the fresh blood into the brain. The veins bring the used blood back from the brain. If you think about it, it is every time your heart beats, brain claims 30% of the share. So each minute your heart beats roughly 72 times, and 72 times 30% share. It is that is the blood going into your head, and it has to come out. But unfortunately, the patients with the IIH has the narrowing of their outflow, that is the veins. This is the main central vein in the head. When it goes to the back, it splits into right and left, and it should keep going outwards towards your ears and make a turn behind your ears and goes down into your neck. And if you look at these arrows in the second picture, that is where it is taking the turn behind your ears, you see the narrowing. That is the cause of the problem. And if you look at the bottom picture in the color, and you see the narrowing of the vein here suddenly going off. So that is where the narrowing is. Next one. So one important thing, when I said before, the main vein goes to the back and splits into right and left. That classic pattern saying the normal caliber both right and left is seen only in 30% of the population. Majority, that is 70% of the population, you have only one good vein. The other side is small or not even existing. What does it tell us? Means to have a normal symptom-free life, all you need is a one good vein. And that means we need to treat only one side, that is a dominant side or symptomatic side for these patients. But that varies with some exceptions, and that's why we need to review the MRV and individualize the treatment for these patients. Next one. So the other reason is the sigmoid diverticulum. So where it takes here, when you look at it, the main vein takes a right and left, and behind your ears, once it take the turn, you call this as a sigmoid sinus. And sometimes the sigmoid sinus, because of the underlying narrowing, it expands and forms an outpouching or a diverticulum that keeps eroding into your bone behind your ear. If you feel behind your ear, there is a bone that is called mastoid bone. And that bone is one of the stronger bones in the body. And because that bone harbors the most delicate hearing apparatus. So that is how we were, protecting our hearing apparatus. And even that bone is getting eroded by this venous diverticulum over a period of time, and that tells this has been there ongoing for some time. When there is a diverticulum, it is erodes all the way, and then that is causing the tinnitus for these patients. Again, whenever there is a diverticulum, there is almost always an underlying stenosis. You need to look for it. So that's why you are treating with the stent assisted coiling. So stenting will take care of the stenosis, and when you do the coiling, you are taking care of the diverticulum of these patients. Next one. So it is in order to show the pictures here, these are the normal caliber veins, and the ones with the red circles show where there is a narrowing of these veins. And these treatment is, like I said, we treat majority of the patients only on one side, and you travel inside the veins and drop a stent, so you are reopening that narrowing. So these are minimally invasive procedures. We are not opening head. There is no open surgery. There is no sutures. There is no cutting open. We do this either under sedation, or in some patients, because of the respiratory issues, we do this under general anesthesia. And everything is done through your antecubital, through your elbow vein. And like if you have been to the hospital, they use an IV line in your hand, in your elbow, to give you fluids. It is the same vein we access, and through that vein, we travel inside, go up, and go into your narrowing, and cross the narrowing, and drop a stent and come out. So when you wake up, practically you will have the same thing. When they take out your IV line, there is a dressing in your elbow, and that is what we are doing for these patients. And the patients will be on blood thinning medications, aspirin and Plavix, for 1 month after the stenting, and we will cut down to the single agent after that one. And it is especially for the tinnitus when we choose the patients carefully, and it is in a selected patients, these are pretty much immediate results. It is patient wake up and the noise is gone pretty much on the table right away. And we check all these patients, the flow distribution has restored back to normal at the end of the procedure. Next one. So what happens, it is the patient wake up either from the sedation or general anesthesia. That is, we are more curious than the patient to know, do you hear it? So that is the first question we ask. And in the recovery, we keep them for observation for overnight, or in some patients, we send them the same day home. And usually we ask them to take it easy for the next couple of days. And we have the patients who go back to work within the week, or students who go back to the university after 3 days. And it is basically a minimal downtime patients having. There is no anti-seizure medications or prolonged hospital stay and these things that is associated with any open surgical procedures. Next one. So basically, I want to give you the take home at the end of the day is this is what I told you in the beginning. It is by the time patients come to see me, they already saw the physicians. They were told, learn to live with the tinnitus, find the way to work around the tinnitus. But in reality, this is a treatable and curable condition. Like with anything, we need to investigate the patient, we need to understand what they're telling, and we need to choose the patient correctly. When we choose the patients correctly, it is an immediate resolution of these patients when they wake up from anesthesia or sedation. And the results are pretty much, it's the permanent results, long lasting, it's a life changing outcomes. It is, I urge you not to, without having a proper evaluation or investigations, it is you don't have to accept the years of sleep deprivation or inability to concentrate or focus at the work. Excuse me. So what makes it a possible at our place at the Cornell is it is a multidisciplinary team. It is it is not a one-man show. Medicine was never a one-man show. It's a team effort. It is a group of neurointervention team and neurosurgery. It is ENT and ophthalmology and more importantly skilled supporting staff. That's what it's a team effort. Next one. And I'm happy to take any questions. That is our office number and my email, work email. So I'm sure it is with the time we have. It is, I know I want to give more time for the questions than the presentation. So if we can't reach the questions, I'm happy to answer them on email or yeah.
Yep. Thank you so much for that comprehensive overview. So we had some questions sent in beforehand, and we have some questions in the chat. So I'm going to go through the questions we sent in beforehand, and then we'll get to the ones in the chat. So the first one, I've had an MRI and MRA that both came back normal, but I still have pulsatile tinnitus that's really affecting my sleep. My doctor said there's nothing wrong. Should I push for additional testing?
Definitely. So when we see the tinnitus, it is, I was talking about the arterial, venous, and in between arterial venous. Remember, 80 to 85% of the times the cause is the venous, and somewhere between 10 to 15% is the arterial, combined arterial and arteriovenous. But we pay so much emphasis on the arterial and arteriovenous reasons because of their associated risk of bleeding or a life-threatening risk from them. But the most common, like 85 to 90%, it is the venous is the cause, even though it is not a life-threatening in terms of they don't bleed, but they make the life miserable. That is the quality of life. So that means, yes, by having an MRI and MRA, you had excluded underlying brain structural problem and also arterial problem, but you have not evaluated for the most common pathology for the tinnitus, that is the venous problem. So you need to have an MRV brain with and without contrast before we do anything, before we exclude the underlying causes.
Great. The next question, how do you determine if someone is a good candidate for venous sinus stenting? I've been I've been diagnosed with venous sinus stenosis, but I'm nervous about having a procedure in my brain.
Okay. So the most of the time, we start with the non-invasive. It is, I'm an interventionalist, but just because I have a hammer, not everything is a nail. So I don't want to start sticking needles into the people. We start with the non-invasive. It is, that's where the MRI, MRA, and MRV comes in. So once we have the invasive, we see the stenosis, then comes the question of where do you fall in the spectrum, like in terms of the severity wise. And that's where we do the venogram and manometry. Same again, we go through the IV axis and go up, and we keep the patient awake, and it barely takes 10 to 15 minutes to do the venogram and understand the severity of the stenosis, and also to understand what is the pressure difference across the stenosis. And that is one of the criteria. And also we try to mimic the real-time scenario by turning the neck and see how the pressure changes or how the flow changes, because the flow dynamics is different in each patient. And finally, the main piece we put together is with the patient symptoms at that point. So that is how we evaluate. But compared to, I mean, we should not say these are a zero risk, but the venous interventions are anywhere in the body, the venous interventions are much, much safer than the arterial, but these are not zero risk. So, and see the person who is do them more commonly, it's basically finding a more, um, more experienced and comfortable person doing these evaluations.
Fantastic. And just to answer the question in the chat, the recording of the webinar will be sent out tomorrow to the email that you registered with, and it will be on YouTube, so it will be available to share. Amazing. We have about 9 minutes left, so we'll get through a few more questions. I've read about other treatments for pulsatile tinnitus, like sound therapy and cognitive behavioral therapy. How is venous sinus stenting different, and when would you recommend the procedure versus other approaches?
So that is the answer is in the question. It is the behavioral therapy and cognitive therapy. Yes, you are trying to mask the symptoms. You are not one. You are, like I was telling. It is probably 1 second. Can you go to the slide 10, Rebecca? This is
Yeah, of course. Where is that? Is that 10? There we go.
Yes, that's the one. Thank you. So this is basically a severity of the things, and it is completely patient telling us how they feel in terms of the quality of life or impairment. And when we focus mainly on the grade 4 and grade 5, and sometimes in patients we are impairing the quality even for the grade 3. That is when we see take them for evaluation with the venogram and manometry. And we know, like I said, it is any patient, appropriately selected patients. It is when they have the clear-cut stenosis, post-stenotic diverticulum, or clear pressure gradient across the stenosis. So these patients, then we know it is, yes, I can help you. This is a very it is a minimally invasive procedure. It is a procedural risks are low risk of procedure, and there is a very high chance of your procedural symptom relief completely immediate. And that is one patient we offer that stenting. Whereas still, one of the slides I showed you, 1/3 of the patients, we don't find a cause in spite of our efforts to find it is not vascular. Then we go down to the thin cut CT to see if there is any temporal bone dehiscence or the semicircular canal dehiscence, any bone causes. Even if we don't find any reason for underlying, then there is no point in offering a stent as to expecting a miracle to happen. Those are the patients I would say go for the cognitive therapy, behavioral therapy, and sound masking and these things to see. If I can't find a definite cause, if I can convince myself I can help the patient, I can convince the patient. That's the bottom line. That's my take on that one.
Absolutely. No. Go back to our Q&A slide, and then I'm going to pull one from the chat.
Sure.
So this person asked, I'm curious about the connection of pulsatile tinnitus to headaches. I am in my mid-20s and have had PT for about 2 years and also struggle with TMJ/headaches.
Interesting. It is thanks, that's been brought up. It is probably almost like 7 or 8 years back, we published a paper. It is on that one we highlighted saying it is patients, there is a clear overlap of patients with IIH, that is increased intracranial pressure, and tinnitus. So when we are evaluating the patients with the tinnitus or IIH, please look for the other symptoms as well, because this is a spectrum. So yes, we do see the element of headaches in patients with the tinnitus as well. When they are present, that means it is an underlying problem is still the same, but you are having different manifestations. Like there is an increased intracranial pressure. Like if you think about the skull, what are the when there is increased pressure in the head, either you are seeing the headache, generalized headache, or the retroorbital pressure, behind the eye pressure, or the noise, and even in the worst case, patients experience leaking of the fluid through the nose. So these are all the manifestations. Not every patient will have every symptom. It is the headaches is one of the common symptom, and that is followed by tinnitus. So these two are the majority of the patients will show these ones. And a smaller group, like a 1/3 of the patients will have the eye symptoms like papilledema, swelling of the optic nerve, and these things. But yes, the combination of these symptoms is a very well-known entity, headaches and tinnitus.
Mhm.
But this is that does not mean you are having two different problems. You are having two different symptoms of the same underlying problem.
Great. Thank you. And then I'm gonna read one from our Q&A. Can severe acid reflux cause pulsatile tinnitus? My pulsatile tinnitus started when I was suffering from severe acid reflux. I am taking a PPI daily and my acid reflux is under control, and I feel my pulsatile tinnitus is not as loud.
At least in the literature or in my experience, it is that is not the acid reflux or the tinnitus are not directly correlation is reported or published so far, or I have not seen in my practice. One thing it is is if there is an associated increase in the BMI, in the overweight, because the other way, if you look at it, acid reflux is associated with the increased BMI, overweight, and these things. Yes, the patients with the overweight are known to have an association, not causation. There is an association with IIH. So the IIH patients, that way they can have the headaches and the tinnitus. But direct isolated, in the absence of IIH, direct isolation of acid reflux and tinnitus has not been reported or published.
Got it. Thank you. And then another question from the chat. Does the patient have to remain on blood thinners long-term after treatment?
No, there is an individual variation of the individual practice physician variation of this protocol. So I can only comment on mine. My standard way is I start them on two blood thinning medications, aspirin and Plavix, 325 milligrams of the aspirin and 75 milligrams of Plavix, a week before the scheduled procedural or a stent date, so that they reach to the therapeutic levels by the time we treat the patient. And I will continue the patient on both the medications for 1 month after. And at 1 month mark, I will stop the stronger medication, that is a Plavix. And I will continue them on aspirin 325 milligrams for 2 more months at that point. So at 3 months, I get an MRV for all these patients. And following once we check the MRV, I will drop the aspirin to the baby aspirin, cut down the dose from 325 milligrams to 81 milligrams. And I want them to be at on that dose for 6 to 9 months, baby aspirin. And after that, it is, I will, patients more than 50 years, I would suggest them, more than recommending them, I would suggest them to continue the baby aspirin for multiple different reasons. But younger ones, I will stop them. I mean, even in this period, practically after 3 months, even if they have to go for suppose a dental workup, biopsies or anything, if they have to stop for 5 days, I am okay with that one. It is not a big deal in those patients.
Mhm.
And one thing I would urge more in younger patients in the childbearing age, I say is if you any reason go back on the birth control pills, I want you to start on the baby aspirin again. As long as you are on the birth control pills, you will be on aspirin just to avoid that risk of a clot formation.
Mhm. Well, fantastic. That was an amazing presentation. I feel like we all learned a lot tonight, and I appreciate everyone being here. I have dropped in the chat for anyone interested in learning more or scheduling a consultation, our number, our website, uh, Dr. Boddu's number and email are on the screen, and we will be sending out a recording of tonight's webinar within 24 hours to the email that you registered with. Thank you again to Dr. Boddu for sharing your knowledge. We really appreciate it. And have a great night, everyone. Please be well.
Thank you, everyone. Thanks for joining us. And Rebecca, thank you for organizing this.
Thank
Appreciate
you.
it.
Have a good night.